Well, good evening. You're live with Faye on YouTube. Thank you for joining us. We have a really interesting conversation up for you today. I'm quite excited about it, and I'm extremely excited about the panel we've managed to put together. Before we get into it, the rules of what we do: this is not a television debate. Thank God for that. This is a discussion, which means we'll be taking a lot of your questions in the chat window through the conversation. Also, we haven't pitted two sides or two opposing thoughts, so they're not going to be arguing with each other. What we have are people who understand every aspect of this conversation and who will be able to give us as much perspective as possible. So as citizens, you can make up your mind of what's really going on. The story that we must talk about is not such in pilot, because really there are more important things going on in our country. The story that we must talk about today is the fact that we have, as a country, crossed 1 million COVID cases today. Now, there have been a lot of arguments. I know people have messaged me, called me over the last couple of weeks saying to say the total number is actually alarmist. We should only be looking at the active number of cases. But if we look at the total number, and if my team will just put up the simple line graph of how these numbers have been moving over the last couple of weeks, you'll see that around the 3rd of June, we were at, I think, 2 lakh cases, and we've gone from 2 lakh cases to 10 lakh cases in about a month or so. So the pace at which the number of cases is growing is of concern. The other piece of information that is of concern is that the total number of cases being reported per day. Every day is a new high, which is why you'll see that spike. And you'll see that just in the last 24 hours, we've reported 34,956 cases. And this is, in fact, a massive spike from what it was a couple of days ago. So we were reporting about 25,000 cases about a week ago. We're now reporting 34,000 cases, and that is reason for concern as well. The third point that we must worry about is the testing information. Now, we're testing, as of today, 10,055 tests per million population. Is that enough when we are at 1 million cases? Is 10,000 per million enough? That's the next question also. And the thing to worry about is positives. You'll see that from the number of people being tested and from the number of those tests that turn out positive, it's actually quite a large percentage. And we'll put up all of this information on your screen through the course of this conversation. But let me talk about the questions that we're going to be asking over the next 1 hour. Question number 1. At 10,000 tests per million population, is India testing enough? Question number 2, India crosses the 1 million mark. Is the worst yet to come? And question number 3, many of the states are now choosing, and cities are choosing, to relock. Is a new lockdown, or we headed for another lockdown? Is that the solution? Let me just bring in my panelists, and these are very cool people who've actually spoken to us through the course of this entire pandemic. So I'm really happy that they continue to give us their time. Dr. Sanjay Nagral is with us, his voice that I greatly respect on the matter of ethics and healthcare in India. We have Dr. Shahid Jameel, one of India's foremost virologists and the winner of the coveted Shanti Swarup Bhatnagar Prize in 2000. Also, my team has put a little note, in brackets that says he's really cool. So to our audience, he's really cool. Dr. Tanmay is an epidemiologist, and Dr. Shruti Tandon is with Jaslok Hospital. She's an intensive care specialist. She's actually been running the program there at Jaslok Hospital through this entire pandemic, looking after very critical patients of COVID. I welcome all of you to this conversation. Thank you so much for making time for us. My first question to all of you is simply this. At 1 million right now, is the worst yet to come? Is this our peak? How do we know if things are going to get worse before they get better? Dr. Jameel?
Faye, first of all, I wish my son was seeing this because he doesn't think I'm cool. 1 million is just another number. Yes, we should be concerned about 1 million because we are also number 3 in the world right now. But to me, something more alarming is that the outbreak is growing at the rate of about 3% per day. We're
Mm.
adding 30,000 cases per day, and I'm talking about a moving 7-day average. So that's to be of concern, because if the outbreak keeps growing at this rate, next month you'll have many more. The month after that, you'll have many more. And whatever ICMR Zero survey that was done in the end of April showed,
Mm.
based on that estimate, today we already have 150 million cases.
Yes.
Infected people, not cases. Okay, so there's a distinction between those. Again, I don't want to sound alarmist. I'm just giving you the government's data. The government survey showed that 0.73% of the population that they surveyed had antibodies, which means that they had exposure to the virus. And this was a sample size of 26,000 over 65 districts. If we extrapolate this to the country of 138 crore people, then in the end of April, we had 10 million cases. Give it a doubling time of 20 days, and you come up with a figure of roughly 150 million infections today. The outbreak is growing at a fast rate, and that's what worries us a lot. So yes, it's to worry about, but don't focus too much on the number. The number is just any number.
Well, I'm going to ask my producer Ira to put that positives versus negatives of cases up on the screen again. Now, this is the ratio of the number of tests that turn out positive. And I am being told that this is an important number to look at. And we'll see, there it is. So you can see the positivity rate is the red line, and it's been climbing quite steadily along with the number of samples tested. Dr. Jameel, what does this mean? And this is, let me point out, an infographic from India Spend, which is a company that does data research for journalism. They do an excellent job. Is, in your opinion, is that red line worrying that the number of tests that turn out positive is also steadily rising, which means that the rate of infection in the population rises along with the number of tests that we're conducting?
Absolutely. And as long as that curve keeps rising and doesn't flatten off, it means that we're not testing enough, because we're essentially finding more people when we test more. And a few days back, the chief scientist at WHO, who happens to be an Indian, Soumya Swaminathan, who's the former Director General of ICMR, had said that if you test 20 and find one positive, then you are getting close to the right figure. India's figure still shows that we are finding one positive after 8 to 9 tests, which tells me that we need to increase our testing capacity in about 2.5-fold to at least reach that number which WHO is projecting.
Right, and the end of that, one quick question before I bring in the rest of the panel. We actually see those two lines merging at, on this current date. What would you read out of that?
Well, I don't think that merge has anything of relevance here. Yes, the number of samples being tested daily is rising, but so is the so are the number of cases being detected. And as I said earlier, unless that red line reaches, flattens out, we are not testing enough.
Okay. Okay, Dr. Jameel, let me bring in the rest of my panel as well. If I may ask Dr. Nagral, what part of the data is worrying you the most, Dr. Nagral? For me, I'll tell you what part worries me the most. The fact that the media now has gotten completely distracted. When we were at a few thousand cases, everybody was putting out information, telling people to stay at home, telling people to wear masks. And now everyone is, obsessed with what's happening with Sachin Pilot and the government of Rajasthan. We're not talking enough about the risk. It's almost as if, it doesn't matter anymore. I want to understand from you what you find most worrying in the data that we were looking at. Dr. Nagral? You're muted.
Sorry. So, Faye, I was saying that, as you know, unlike Dr. Jameel or Dr. Mahambatra, I'm not a COVID specialist or a epidemiologist, but of course, I've observed this situation very closely in Mumbai. In fact, I remember that in March, I appeared on your show, and one of the things we would very carefully say at that time is that we hope we are wrong, but this epidemic is going to be big in India. Our healthcare system is going to be challenged. Unfortunately, we were right, I think, and I think it's something that has taught us a lot of things. You're absolutely right. We seem to be reaching a situation where there is a certain fatigue, and therefore people are moving on to other stories. Of course, it's also about TRPs. You know it better. You're from journalism, but so it's about TRPs. But so there is a certain fatigue, but the fact of the matter is on the ground, Shruti will tell you that the situation is still quite bad. The way I look back at the last 3 months is this, that, you know, what we were most worried about is the fact that the fault lines in our healthcare system are going to be put to severe test. And that's exactly what has happened. And it's gone a fairly predictable way in terms of the fact that the public hospital system has collapsed. The private sector has done its own thing. There's a lot of profiteering. What we're beginning to see, I think, in the last month, at least in Mumbai, is perhaps for the first time an attempt to have a coordinated action. How much that is going to impact on the management of patients, we'll wait to see. But for the first time, I've seen in the last 30 years a telephone line in Mumbai, which you can call and you'll actually get an answer which tells you where there is a bed available. So I think if this telephone line was in Mumbai 30 years back, Faye, we would have said about 50,000 lives of people who, you know, with accidents, etc. So I think we have moved a little ahead.
But Dr. Nagral, one second, before you move on to your next topic, here's the challenge. The problem has also moved outside of Mumbai right now. The problem is in Thane, in Bhiwandi, in Raigad, in Pune, in other parts of the country as well. We're seeing the problem leave the cities and pop up in tier 2, tier 3 cities or towns, where we know we don't have the kind of healthcare that even a Mumbai or a Delhi had. And when I say even, because this is the best healthcare in the country, and it really cracked under the pressure. So will it be important to just take the learnings of Mumbai, Delhi, and quickly start to replicate and apply in other cities?
Absolutely. And I think both Delhi and Mumbai have learnings. Shruti will probably in a better position to tell you exactly what Mumbai did to an extent. Although I'm not one of those who believes that Mumbai has done a fantastic job. I think they did a lot of things delayed. But certainly there are learnings. And one of the learnings, I think, is that everybody doesn't need to rush to hospital. There are lots that can be managed at home. We need triaging. We have partly started doing it in Mumbai now. So these are the lessons to learn. Having said all this, we are very well aware that once you go outside Mumbai, hours away from Mumbai, the healthcare system is quite poor, and therefore, when it moves to those areas, yes, we are going to see a lot of dislocation. Mumbai collapsed. You know, there was a time in Mumbai where people were moving from hospital to hospital and dying in ambulances. So you know, it's very worrying.
Yes, Dr. Shruti Tandon is with us as well. Dr. Tandon, I visited your hospital at Jaslok. We looked at the triaging area where every patient who was brought in from a separate entrance was either, you know, was COVID until proven otherwise, kept in a separate area, tests were done, you know, treatment was done in that separate area until the person tested negative. Can there be that manual that Dr. Nagral is talking about that can be written out for other cities so that we don't waste or we don't lose the kind of time that Mumbai lost in getting on top of the problem?
Yeah, so it would be ideal if, you know, there would be a sharing of knowledge and information, and this kind of model would get implemented. So there was a time when we suffered also at the hands of an outbreak. And I think everybody remembers it correctly. The media, at that time, we were the media favorites, and it was flashed all across that our hospital has shut down, though we never really shut down our COVID ICU. And I'm proud to say that we've been running it since March end. But yes, so it would be lovely to share models, but you know, somewhere I think this is a country where we want credit for things we do. And we also look at different instances to make profit. So lessons learned from Mumbai, yes, definitely now that Mumbai and many hospitals in Mumbai, not just Jaslok alone, have good models of screening patients. And when we talk about screening, we don't do swabs on every patient, but we have a questionnaire which is ready. We have trained our personnel to look for COVID or COVID-like symptoms, and only in suspect patients to send the swabs, keep them in a holding area, admit them if necessary, and watch them till you have a swab negative, first swab, third swab, sometimes even a seventh swab is done, because that's the way the disease is. It can trick you at times. We've had patients who had 2 swabs negative and then surprised us, and then a lot of other people exposed. But now we seem to be ready with it, because even staff in that area where the third swab has turned out to be negative, when they are screened, they have not turned out to be positive, because we have protocols in place. So yes, if there was a way to share these, I would love to. And Faye, by being the reason why I like to come on these shows, I think there are a lot of viewers who watch this. People have reached out to me. There are people who are doing great work in public health, and they've reached out to me to set up protocols and PHCs. But it's very, very piecemeal. There is no integrated system. So there's somebody who left a job in the US and got here. He's not a doctor, just in management. And this is like just one example. And when I asked him I thought he's going to set up an integrated public health system in Maharashtra. So I'm really excited to help him out. But then he talks about a few places in Mumbai that he's covering, another few spots in Udaipur. So it's, very peaceful. What we need here is a good integrated system. The other thing which disturbs me about the graph which you showed us, go back to that, is that, and maybe Dr. Mahapatra and Dr. Jameel will be able to help me. If you look at that graph, in May and was the time where testing was very, very difficult in Jaslok, in Mumbai.
Yes.
So in areas where the number of tests was low, but still the positivity rate was rising. So imagine what all we've missed over here, because the testing was so stringent, and end of June to July is the time where we've actually enhanced testing. So these were definitely patients who had symptoms in May, because without symptoms, if you test, you would risk losing your license. And the patients who were tested post, I think post July, or say post last week of June, are people who, anyone who's not even a contact can just walk into a lab now. Since the last 2 weeks, you can walk into a lab and just get yourself tested. Maybe somewhere post mid-June, all contacts of positive patients could get tested again. So even with the change in testing policies, the graph has continued to rise steeply, both the red line and the green line, which is a big concern. Now, learning lessons from Mumbai, which I did part of my education at AIIMS, and I keep in touch with a lot of my friends in Delhi. And I realized that one of the changing points for Mumbai is when we involved private hospitals. So nursing homes taking COVID, the nursing homes were told that you have to become COVID centers. Private hospitals were told that 80% of your COVID beds need to go at a subsidized rate. And I do now realize, because we are now working very closely with the hospital management to get protocols integrated. There's a lot of my time which is spent in non-clinical work. And I do realize that the management, it must be struggling to make a profit at those margins, but which is fair enough, but they're just happy to be doing this kind of work. And that has eased the load on a lot of doctors. Now, when I spoke to my colleagues in Delhi about 1 month ago, that was not the case, but I believe in the last 2 days, on that Guru Purnima day, I messaged my guru in Delhi and he said, no, now things are like sorted in Delhi too. So private sector has been involved. Before that, we were hearing those exorbitant things about 70,000 or 1 lakh rupees a day. Yes, and triage, I think, is a huge thing. The fact that people in Mumbai are being allowed to home isolate, home quarantine when they have facilities, even people with risk factors. And I spend about an hour or two every day, typically between 4 to 6 in the evening, often managing patients at home. So people call me up and ask me, am I a COVID specialist? I'm not, but I guess now everybody who's been working in this has become a COVID care specialist. So, and it's really encouraging, because so many of them at home who are above the age of 55, who have comorbidities, cancer survivors, people with active cancer, are finish their 14-day quarantine and recover from a mild infection. So when these people are not occupying hospital beds, that leaves a lot of room for patients who really need.
who really need it. I just want to put this up on the screen as well, and I'll take this question to Dr. Mahapatra. Dr. Mahapatra, good evening, and thank you for listening very patiently. There was an article by Devi Shetty in this morning's news, Dr. Devi Shetty in this morning's newspaper, and it said very clearly, and this is true, beds don't treat patients, doctors treat patients, and they are in short supply. He also goes on to say that leading epidemiologists predict that by the end of the year, India will have millions of infected patients, vastly higher than the numbers that we currently see. Let's prepare for the worst and pray for the best. Dr. Mahapatra, what is your prediction right now? Are you predicting also millions of cases by the end of this year?
Definitely. First of all, few minutes back, you were asking that which are the figures that actually worrying us the maximum, and the answer is this. In a country like us, in a situation like COVID-19 pandemic, when we are actually dealing with a virus which has very high infectivity and very low pathogenicity, there is a high likelihood that we will be talking about millions of cases when multiple millions are asymptomatic and about which we actually don't know. Now, the point is, when we are dealing with these patients, we have to think about the other factors like the comorbidities and other aspects, the age and any pre-existing illness which is aggravated by being infected by COVID. All these things need to be carefully handled with a certain optimization. And for that, we need doctors. The prediction in a pandemic, when we are actually going through the exponential phase of the epidemic curve, there is a high likelihood that nowadays we are having 30,000 cases, 35,000 cases per day. It will increase to 50,000 and more very soon. And today, 1 million has become a kind of a landmark. Someday we will actually be reaching somewhere. The day America reached 1 million, there were lots of noise. Now, when they are actually going through multiple millions, there is also the same kind of fatigue. The point is, the numbers, as Dr. Jameel has mentioned, this is just a number. But the point is, what is concerning, the more we are dealing with this particular virus, we are having our doctors more and more affected by it, and we are having from the frontline treatment pool, we are having different doctors either temporarily or unfortunately permanently being removed from that particular pool. India is not in a position to afford this. And that's why we really need to think of how we need to handle this whole scenario. And these multiple millions that my predictions are talking about at the end of this year, we need to handle this very carefully. Because another point is, the other point that I'm very much concerned about is, we are talking about COVID, which has much less mortality than any other illness. But what is actually happening with other kind of ailments that we are actually talking about as the premorbid conditions where people dying being infected by COVID. Now, the point is, right now, if I feel sick and if I want to go to a hospital, I really don't know where I have to go. And the problem is the whole health system is so jeopardized in the way that having a COVID positive patient, what exactly they are going to do with them, and as opposed to having another patient, what has to be done there in both in private, public. I'll be saying that even government sectors are doing good here. In the private sector, it is actually quite dismal in different cities and all other stuff. And another very important point is the stigma. Now, right now, actually feeling I'm having fever and I'm having sore throat. This is probably a big stigma than anything else. Nobody is actually inclined to tell that to anybody. So we are actually getting cases, even for testing, even for treating, when they are actually in a certain complications are developing. This stigma is something telling us that we are not learning how to live with COVID, and this is killing.
I'd like to add something to that.
Just before you take it up, Dr. Tandon, there are a couple of points that have come in. Manisha and Hiren are thanking everyone on the panel for giving us your time this evening, their viewers. Sai Krishna says, could you also tell us about the various diagnostics available? Because right now there's the rapid testing, antigen testing, antibody testing, along with the PCR test that was already available. So while you add to this, Dr. Tandon, do you want to just take us through what the other tests are and what purpose they serve?
Yes. So, I couldn't agree more about what Dr. Mahapatra said, that stigma with the disease is so much. And this is the disturbing thing, that there are people who, at the instance of getting fever, so that, combining both the questions, the gold standard is the RT-PCR or the nasopharyngeal swab, where you do the traditional swab test, which is supposed to jerk a tear when it's done. Short of that, a person who has COVID-like symptoms often comes to us, and I would agree with you that the number of healthcare workers is underrepresented because there is so much stigma on this. Most people feel that you get COVID because you didn't wear your PPE properly, but there can be a lot of other exposures which can cause COVID. And what has happened is, and remember, if you're a healthcare worker and you've got COVID, it's because you were working and you were not sitting at home. So that first line of credit to you. But there are people, even healthcare workers and a lot of people in the community who will have an HRCT test done, who will have blood tests done, who would have taken remdesivir, tocilizumab, steroids, the works. And then we get panic calls saying that, look, we're having fever from so many days and now we are feeling tired and breathless. So can you get us in? And the only thing missing there is the RT-PCR. I mean, what have you treated yourself for? You don't even know, you don't have a diagnosis in place. So I think that stigma has to go. A lot of this practice is also seen in smaller cities where I believe in places like Surat, correct me if I'm wrong, but patients from there contact me and tell me that if you need to get a COVID test, at least till some time back, you need to get admitted in, and you have to go to civil hospital, which, Surat is a tier 2 city. It's something which is coming up. I'm sure there'll be a lot of cities where testing is not so freely available. So they would not even get tested, but get all kind of investigations done, get all kinds of expensive treatment. And, I've been saying this right from the beginning, Faye, that the treatment of COVID is not expensive. Remdesivir is expensive, but remdesivir is not the crux of treatment. Tocilizumab is expensive, but believe me when I say it, that in the last 4 months, all the patients that we've given tocilizumab to have perhaps done worse than the patients who we treated only with steroids. And that was way before the positive study on steroids came in. So we gave up giving tocilizumab because we realized that you burn a hole in the patient's pocket, and then the patient lingers on longer in ICU. Most of the times they don't make it. This is our own personal data. I know worldwide people may have different things to say. Now, coming back to the tests. So I want the viewers to understand that the only gold standard is presently available is the RT-PCR or the nasopharyngeal swab. It has about a 70% chance of showing you that you have COVID, and it is 100% specific. So you are not going to get a COVID test positive and in an event of having some other illness. If it comes positive, you are positive. If it comes negative, there's a 30% chance that it may have been missed. In which case, like I said, we repeat a swab at day 4 or day 5 and another one at 7 or 8 if the symptoms are strongly suggested. We don't do more than 3 swabs.
Yes.
Now, there is testing which has come in with regards to antigen testing and antibody testing. There is not much evidence for either of these. Okay, some of these have a sensitivity of about 50%, which is really, as one of my colleagues mentioned in a meeting that Dr. Nagral was there too, in the hospital meeting, it's like flipping a coin. With the antibody tests, it's only a retrospective diagnosis. Again, there are 2 parts of the antibody test. There's an IgM level and an IgG level. Now, both the antibody tests, we found them to have a very high false negativity, which means that patients who have recovered from COVID, even after they've recovered, when they've come back to the hospital for some other reasons, we've done antibody tests on them and found that weeks later, the antibody is still negative. And these are patients who were RT-PCR positive. So it's not foolproof. Okay, the test is still possibly evolving to achieve better sensitivity or specificity. There was some talk about doing a gene expert, which would have then avoided getting dead virus, which is the one criticism which we get for RT-PCR, that sometimes it's just picking up dead virus and replicating the bits and pieces. But gene expert has not come into the picture. Lastly, there is, I think one of the biggest knee jerks is the moment someone has fever, they say, okay, get into a hospital and do a CT scan. It's really tragic, but Dr. Nagral, I haven't even shared this with you. A 9-month-old child in Surat. Okay, this family from Surat contacted me. There's a 9-month-old child whose CT scan was done because he got fever and the rest of his family was COVID. I mean, I shudder to think of it. I told the mother, I wish you called me before this scan was done. And how did you sedate the child? What did you put the child through? So CT is not something which is going to diagnose COVID. We do use CT scan in our hospital, but we use it to exclude COVID in a high-risk patient. But it's not a diagnostic modality. You can't see a CT scan and say this patient has COVID. So it has no role in making a diagnosis. And I think that has become a knee-jerk reaction often. In fact, if you look at recommendations of all the societies, the American College of Radiology, you look at the Canadian Society,
Yes.
European Society, everybody talks against these tests. But somehow in India, I told you, it's the more expensive the test, the more expensive the treatment, we tend to
think that it's better. All right, so I want to open this up now to the whole panel, and I'll start with Dr. Jameel. When we had just a few thousand cases, Doc, we went into a full lockdown. We now have a total of 1 million cases. Obviously, the infection is still spreading. As much as the government might want to deny community transmission, I don't know how one gets to 1 million cases without community transmission. Do you believe we're headed for another lockdown, or is it going to be the piecemeal, state-wise, city-wise thing that we're doing? Will that do the trick?
Well, first of all, the first lockdown. The lockdown did work. When we went into a lockdown, our doubling rate was about 5.5 days. When we came out of the lockdown, it was 14 days. It has gone up now to about 20 plus days. So the lockdown worked, but the lockdown is not the solution to contain the disease. The lockdown is time for you to prepare your healthcare system, to prepare the contact tracing, to make sure that you're doing enough tests. And that is something that we came out weak on. We didn't really get, so far we're not doing enough tests. And I keep hearing this, that India has done so many million tests. The same people who will tell you that India has so few cases per million population or so few deaths per million population will not tell you about tests per million population. They will tell you about tests in absolute numbers. That I call cherry picking data to suit your narrative. If you look at tests per million, that's also low. That's about running at around 9,500 per million population, whereas some country like US has something like 130,000 per million population. So you can't be cherry picking data. That's one. About whether we are heading into another lockdown, I doubt we are heading into a national lockdown, because the national lockdown became something that was giving us diminishing returns. Yet I hope that there would evolve a more sensible, data-based and evidence-based strategy to do lockdowns. UP, for example, these days is having a weekend lockdown. Now, I fail to understand what purpose does it serve? Is the virus only active on Saturdays and Sundays and it's not active on other days? It doesn't make sense. So, I think there is, and we have all these, national advisory committees, and either people are not listening to them or, they're not giving the right advice. Something is amiss here, which, it's not rocket science. It's something very simple.
Dr. Jameel, I'm just looking at the numbers again, and around the 3rd of June, we were at about 2 lakh cases. It took us 18 days to get to 4.1 lakh cases. It took 11 to get to 6 lakh. It took 9 to get to 8 lakh, and 6 from there onwards to get to 10 lakh. So actually, the pace at which this is spreading has increased. So how do we argue then that our doubling rate is better than it was in the beginning?
I'm telling you, at the time, compared to when the lockdown started and when the lockdown ended.
Okay.
We look at that period. So it did increase the doubling rate. But, a lockdown will not contain the disease. Lockdown only gives you time to prepare. And, it's so silly that we are at 1 million cases and still, there is no claim of community transmission. In fact, I saw something very funny the other day. It said, never ask a man for his salary, never ask a woman for her age, and never ask ICMR about community transmission. So, but, jokes apart, I think we are dealing with people's lives here. Policymakers really need to get their act together here.
Yes, and I want to take that point to Dr. Nagral. Dr. Nagral, we've seen many problems on the manner of the ethics in data distribution. So Dr. Jameel is too polite to actually say it. I'll say it. The health ministry actually kept saying that we are at these many cases, but in a population of 1.3 billion, this is nothing. It could actually be much worse. And at the same time, when it came to testing, they weren't willing to compare it to population by million. They just said, look at where we started and look at where we are right now. So there's a lot of there are a lot of smoke screens in the data that the government is sharing. The ICMR and the health ministry stopped doing press conferences oddly of several weeks ago, and then just recently did one. So they're being choosy about what they will talk about, when they will talk about it, when they will answer questions, whose questions they will answer, and what the treatment ought to be. And now we have various state governments sort of figuring these things out on their own. So Patna is in a lockdown, Thiruvananthapuram is in a lockdown, Guwahati is in a lockdown, Pune and Bangalore are in lockdowns, but there's no sort of national mandate on what is being done. First, on the ethical question, Dr. Nagral, should the government be more clear about data and more open about data?
Yeah, so, Faye, it's an old problem, isn't it? That in the Indian scenario, what seems to work is symbolism. You sort of don't really engage with an issue with the depth it deserves, and you can sort of give these messages that we are doing well. For example, one of the messages for many weeks was that India is doing very well. Almost as if the admission that we have more cases is kind of we should be ashamed of it. So that's one issue we have seen. The other mixed messaging we have seen is on the issue of which drug to use. Of course, don't forget Baba Ramdev. Because you have Coronel coming up, and you have a so-called trial, and so it's all about performance. I think it shows our weaknesses in terms of two things. One is our weakness, our scientific institutions are brittle. I think their independence from the official narrative is something that is not there. So you, as in many institutions in India, you generally flow with the narrative. So if the narrative is that we are doing well, everybody is supposed to say we are doing well, and I think that's a problem. Finally, of course, even on the drug issue, and Shruti
Yes.
will tell you this, that the way some of the trials are being done now, with all due respect to these companies, there's a trial right now which has 30 patients in it, 20 and 10. And
are you referring to the Biocon
yes,
trial?
yes, of course, I'm referring to the Biocon, and there are television channels going gaga over it. I mean, we have no understanding of conflict of interest. The principal investigators in the trial are sitting and talking about how good the trial is. I mean, there is something called conflict of interest, which people need to understand.
But Dr. Nagral, I just want to ask, with regards to that particular drug, that drug received emergency approval from the Drug Authority of India, the authority that actually gives out this approval. Now, once that approval was given, the company came out and said, we've received emergency approval, even though we've only tested on a sample size of 30, out of which only 20 people received the drug. The next day, ICMR came out and said that this testing is inadequate. So is the ICMR and this drug controller regulator not talking to each other? And shouldn't they make it at a pandemic be clear about this is the approval we have given under these circumstances? This is what we have said. Shouldn't this be public information?
Absolutely. So, Faye, there is a lot of fine detail there. And I mean, if you want to talk about how approvals go on in India and all, I think it's a separate subject. It's a Pandora's box. But what I also find strange is that the scientific community, and that I think it's one of the responsibilities of the scientific community, to call out these things, whether it is Baba Ramdev or whether it is these kind of trials, to call out, because it's making people desperate. And whether it is remdesivir or whether it's tocilizumab, I mean, people are running from pillar to post, and doctors tell them, go and get this drug, it will save your mother's or father's life. Now, who will of course run in the night, and you may have riots for remdesivir, soon. So I think we should understand that whilst everybody is keen that we get treatment, everybody wants to have that cure, but this is not the way. I think it shows poor science. I think it's also people taking advantage of the situation, unfortunately, to make a quick buck. They know that this is the time to put out a drug and make some noise about it. And you are in India. If you make a noise about some drug, people will start buying it. So I think it's a big problem. And I think professional bodies have a responsibility there to call this out.
So tocilizumab was buy one, get one free before the pandemic. In rheumatology also, it had a very limited space.
Right.
And now it's being black marketed. It's such a shame. We can just sit back and smile, because now we draw solace from the fact that we are doing an ethical practice and we're doing what is right. So you can't control the actions of the rest of the world. But I wish there was some kind of a national advisory which told you, I mean, there is an ICMR guideline, but maybe it needs to come down stronger in nursing homes. So the moment, like tocilizumab is to be used in a very select population of patients who are failing respiratory therapy and who have not responded to steroids. But tocilizumab 1, 2, 3 doses are being given. And patients are going into immunosuppression, then going into sepsis and dying. I mean, it's criminal. It's really what Dr. Nagral is saying, that everybody is sitting with a little ullu of their own, and mera ullu seedha ho jaye, baki jo ho so. But this disease is not going to escape anyone, and if you're not going to pay for it in this world, it's going to happen in another world. I mean, I'm a strong believer of karma, and I just don't know what's wrong with this.
Well, let me now take that then to the panel. Dr. Mahapatra is also listening very carefully. Dr. Mahapatra, as this disease now spreads into tier 2, tier 3 rural India, where healthcare, where science, where doctors, where beds, where ventilators are going to be harder to come by, will we see more unethical practices take place in terms of drugs being sold, black marketing happening, charges of any sort being slapped on patients and their family members?
So, first of all, Faye, I think before going to answer this question, we need to just stop for a while and think why or how we approach the word ethics. Is it my personal ethics, or there is something called, which is a kind of a humanitarian moral ethics, or we are talking about the clinical ethics or research ethics? We are not seeing anything being followed anywhere. So why am I saying this? Definitely, answer to your question is yes. And the reason is, I'm not going to talk about things that are actually going beyond the cities and all that. It has gone beyond the cities. We may not know about all the figures so clearly and carefully, but it's always, if something is happening in Mumbai or Bengaluru or Delhi or Chennai, that comes to the prime time much often, much faster. But definitely things are happening across the country. These questions are actually just spending some time, that whether community transmission is happening or not, etc., etc. In April, I remember in some of the shows I said that whether we are now having community transmission or not, that doesn't matter. The question is, how prepared are we about that? The question is, when we are talking about all these unethical practices, actually all these things together talking about only one thing: we are not growing up to deal with a pandemic. We need to learn. 2018 we have not seen. We as a race, we are seeing this, and that's why we need to learn. It's not today. The first case in India happened in 30th January, and we have spent almost 7 months with it, and till now we don't know how to handle a pandemic. That's ridiculous. And this is, I'm not talking about any government or anything. I'm talking about us as an individual. If government is made of different people, and as a people, we need to actually handle this whole scare, whole everything. What Dr. Tandon was just talking about. We all are worried about what we are going to get. I'm happy in that way. You are talking to me, some audience listening to me, people getting publicity based on COVID. That's not the case, right? It's a pandemic. I may die tomorrow. We have to learn this. We have to understand when we are talking about black marketing of medicine, whom are we actually fooling? The medicine may be required for my daughter. So this is something human being need to learn, not as a state, not as a country, as a human race. That this is the time we need to actually handle this as a grown-up species. What is happening ethical? Didn't we see different journals taking back the articles and all those stuff? That was actually a noble effort. That whenever you have something in the publication, you first put it out as a preprint, so that if there is some matter, people can read about it and the knowledge can go on with the conjectures and refutations. But we started using that in a way. This is the way to get my publications done. So this is happening everywhere. Definitely, as it will go beyond the cities more and more, or I would say, as we know more about the villages and all those stuff, we'll know more about the pathos. But the fact is that as a country, as a race, we need to handle it carefully. We need to have a system which should teach us how to handle this care as a holistic approach. Everybody is scared. I'm working with different type of researchers who are talking about the frontline workers being scared, doctors being scared, the beneficiaries being scared. Women are not coming, taking their babies for immunization. Women are actually preferring to get delivered home because they don't know what will happen in the facility. In the facility, in the health facility, the nurses, they are worried that they are not probably well supported by the community at their home and in the facility with their logistics to be well protected against this being in this profession. Same happens with the doctor. We need to understand. So there is a requirement of having an e-portal, which will be a helpline for everyone to get psychological counseling and all those stuff across the country. And this can in a way develop a community response which can in order actually prevent these kind of black marketing and all those things you are talking about by an accountability, the social accountability that we need to actually build into the population by culture, not by mandate.
Right. Last question I want to take to the whole panel is this, and Dr. Jameel, I'll start with you again. There's no vaccine in sight. Even though the ICMR was hoping that Independence Day would also involve mass production of a vaccine in 4 weeks, we all know that that's not going to be possible. It's going to be months, if not at least a year, before we see a vaccine. So what happens between now and then? Is sanitizing, mask and social distancing the only route at this point? Are we doing enough of it? Is there something government should be doing, citizens should be doing, healthcare sector should be doing that we're not doing? Or have we messed this up to a point where we can no longer put this, put it back into the barrel because it's already spread?
I am an eternal optimist, so I will not believe that there is nothing you can do. Firstly, too much has been made about a vaccine. And by the way, with all that shor sharaba about ICMR vaccine, the Zydus Cadila vaccine has already gone into humans. That trial has started, and the ICMR trial is still awaiting.
Yes.
We have to understand that even if the Moderna vaccine or the Oxford vaccine, whichever vaccine, even if tomorrow it is proven to be safe and efficacious, it will have to be manufactured to scale. So vaccine is not something that is going to stop this outbreak tomorrow or the day after or the next month. The entire vaccine manufacturing capacity of the world is about 8 billion doses annually. And all 8 billion are not going to be making only the COVID vaccine. There are other vaccines to be made. So, the capacity is a few million for COVID vaccines around the world. So even if tomorrow a vaccine succeeds, it will a new set of challenges will be there, who to give it to, and all of those. So don't wait for the vaccine to take this away. Do the basics, test at scale, trace contacts, and do proper isolation. And the best isolation is an isolation within the community. Isolation will not be successful if it is done in a place which people don't identify with. And that brings on all those cases of stigma, of people not having confidence in the system, and all of that. So one final thing I would say is that the thing that actually worries me the most today is that monsoon is here, the dengue season is on us. God knows how much chikungunya we'll get this year. The malaria season is on us. And in 2 months' time, there will be the flu season on us. Now, Shruti and others will tell you that the clinical presentation of all of these and COVID is the same. People will come with high fever. So what happens when somebody with high fever reaches a facility and they're found to be COVID negative? What will they not be treated for the dengue or the malaria? What will happen? Do we have a process in place? So that's one. The second is, with all this learning about various medicines that are available today, is there a clear standard operating protocol for hospitals to use when a patient walks in? So maybe these may be small things. They may not be very fashionable to talk about, like a vaccine, but these will help immensely in the logistics, and these are what is going to prevent further mortality. We're not worried about the infection, we're worried about the mortality.
Yes. Dr. Nagral, same question. Where do we go from here, and what needs to be done in order to keep this under control so it doesn't turn into worst case scenario?
So where do we go from here? So Dr. Jameel said that he is an eternal optimist. I wish I could be, but I hope that we are learning the lessons. There are some lessons which have come out into the public domain in a big way. So the centrality of public health, the centrality of the public health system is one lesson. Hopefully all of us will take that and not look at India's future in 5-star hospitals. That's what we believe for many years. I think my hope also lies in the fact that there is a lot of community mobilization around things like helping with. I'm part of a group in Mumbai, for example, which is doing phenomenal work in getting PPEs donated to healthcare workers. So I think community involvement, and I must say this, that I think, yes, and this is one situation where we can't put the whole onus on the state. I think the people have to understand that they have a big responsibility where it's wearing masks, social distancing. The day the lockdown was lifted in Mumbai, the scene was as if the disease has gone. So, people came out in large numbers. So, we need to understand that. Incidentally, Faye, I also feel that, what this epidemic has done, or this pandemic has done, is that we have, I think, better science discussions and better journalism. And, people we have now a bunch of very good, talented health journalists, and, they're asking the right questions. So I think there is hope. A lot of our young people, I think, are looking at these issues now. And that's where what's going to happen in the next few months, I hope, as we said in March, that we don't face the worst, and that we hope that we do well as a country.
Well, I'm going to knock on wood, because the last time you said that, it turned out to be completely false. So let me just read out a couple of questions. Tanvi D says, how is it the health ministry holds press conferences and says we're very good, but the graph shows that it's hiking? Shouldn't there be an onus then for misrepresentation of that sort? We have a question from Hirin Guhani, who says, if we haven't entered community transmission, does it mean that the initial 30K cases are still being tracked on a daily basis? Roshan Abbas and Pranjali Ingle, who have given contributions to us for the work that we're doing, thank you very much. Dr. Mahapatra, that question is to you. Where is the onus on the miscommunication. I'm going to straight up call it miscommunication, because when the ICMR comes out and says, hey, you know what, this is not so bad, things could have been a lot worse, what it results in directly is people thinking that the worst is over, chalo, let's go out.
I think he's
Let's go out
out
with our friends.
individual ethics.
Yes, so since you were asking questions about what ethics we're talking about, any sort of ethics you want to plug this into, but where is, I mean, the health ministry's responsibility is to contain and to maintain, you know, to bring down mortality, is not to make itself look good, Dr. Mohapatra. Where, you know, where does the buck stop there?
Actually, it all depends on how systematic are we and how the system is built. In a pandemic situation, the policies should depend on the epidemiologists and doctors who are working on these, and virologists and microbiologists who are actually researching on this for long. And then there should be something which is called risk communication. Risk communication is a subject which is taught in universities, and there is some requirement of learning on these, because how we present something, that is very important. A sentence can be having different emphasis in different words, which can be then ultimately interpreted into 20 different ways by people who are actually listening to it. Now, whenever there is a communication about a pandemic, about a scenario where we are going to have a country like India being under lockdown, or having a boon like a vaccine coming into the place, it's always a responsibility for whoever communicating about it, whether it is the government, whether it is an individual over social media, or whether it is about journalists like the ones that we are facing, like you. The point is, we need to understand that there is a lot of responsibility built into the whole process. And by saying something with a little more responsibility and onus, we can actually understand COVID is nobody's problem. COVID is everybody's problem. We have COVID because of which people are not being able to visit their home, people are not being able to meet their next to kin, and every other thing is happening around. So, ये जो सनसनीखेज खबरें बनाने का जो तरीका है, we need to move away from that. Everything should not become something where I can have my kind of first movers benefit or something, a sense of well-being. And it's very common, right, for government to say that things are like this, we have things under control, and then opposition is saying no, nothing under control, everything is in jeopardy, and then it continues to happen like this, and general people don't know, if I have cough, where shall I go, what shall I do? And the other person who is having her his dialysis pending, she or he is not actually doing it, creatinine level is going high, she or he is waiting for the vaccine to come 15 days after. So the point is, that's why we need to have a proper accountability at all places, not for COVID. COVID is a lesson. The way Dr. Nagral was talking about, actually, COVID is a lesson. It's a lesson that we need to learn, not only better journalism, that already it is actually happening around. We need to also learn what does accountability mean. Whenever we have somebody who is actually having a testing done, we should not actually always say, hey, you know, he's actually getting tested. Hey, you know, there is a case in my community. We need to know that everywhere there is an accountability issue. And for government, we need to have a proper system so that communications are made based on the authentic evidence which is put forward and examined by experts.
Also, last question to Dr. Tandon. Dr. Tandon, it looks like we're stuck with this virus for a while. So the behavior that Dr. Mohapatra was talking about, where we put things off, dialysis, other sort of treatments, women who are putting off their antenatal treatment or their scans, their checks, because they don't want to go to hospitals. And we've been told over and over again that we need to learn to live with the virus. What does that mean in your opinion? What does living with this virus really mean? Because you also, and I want to quote what you said on this show a couple of weeks ago, you said, the virus doesn't want to live with us. The virus wants to kill us. So how do we live with a virus that wants to kill us?
So living with a virus that wants to kill us is simply avoiding getting it. And if you think you're getting it, then you have to be proactive and get yourself tested. So don't shy away from it. If you have, it's like the elephant in the room. So if a thief has entered your house, please call a spade, catch him, and get him out. I mean, you probably would be able to show him the door. Yeah.
I think, Faye, sorry for Dr. Tandon interrupting. I think this virus is not intending to kill us. No virus generally want to kill his or her
that was just said in
intelligent virus.
Yes.
Virus wants to actually hide within the host and live happily thereafter.
Yeah, but Dr. Mahapada, that was said more for the lay people who think that they can just live with it. There are a lot of people who think it's cool. Okay, so in that context, in the US, there were a lot of young doctors who at the beginning of the epidemic thought, let us get the virus. We are young, we'll clear it. Yes. And we can then work. And, right now there are beds and ventilators, everything available. Out of this cohort of about 35 doctors, 16 died. And 20 were on ventilator. And these were all young under 30s. So really the virus doesn't spare anyone. And to say that, we're cool and we'll get the infection and clear it out. Dr. Jameel, I don't mean you're cool in the right way. But I am also an eternal optimist. And I really like it when somebody says that, no, it's not out of the barrel yet. We can still contain it. And I do think we can contain it. There are a lot of lessons to be learned. It has hit the metropolitan cities. We can replicate models faster now. We can replicate models of how to inculcate safe practices in the hospital. We can now make testing more easily available, make triage more easily available. And just the way we were making doctors accountable for testing, we can make doctors accountable for prescriptions. So you have to fill in an accountability form before you prescribe a certain drug like remdesivir or tocilizumab to a patient. It's not that difficult. You are putting your license at stake. Maybe people will think twice before they do all this. And at the final stage, the patient is hypoxic, they're shoved into a tertiary care center, explaining to the relative that the patient is sick. It doesn't work that way. And coming back to what Dr. Jameel said, so we are seeing a lot of double infection. So we're seeing a lot of malaria with COVID as a background. And, it just made us wonder that, okay, HCQS is probably helping both. But you would not shy away. And what you said is very pertinent because the diseases you mentioned are potential killers. And like you correctly said, their mortality is much higher than the mortality of COVID. So people don't need to shy away from a fever.
So forgive me for interrupting you, Dr. Tandon. Quick question to Dr. Jameel or anybody else who wants to take it. Is there any evidence so far that someone who has got COVID and recovered from it, so the convalescents and the people who are turning into plasma donors at this point, that they won't get it again? Or is there possibility that someone who gets the virus will get it again? Because people are still asking that question. So for example, if we test for antigens and we find out that we have been exposed at some point, does it mean that now we're cool and we can go out and nothing's going to happen to us? Dr. Jameel, is there any clarity on that?
No, there is no evidence that somebody who has had the virus once will get it again. There has been concern that people who have very mild infection also show very low levels of antibodies. There is a recent paper that has come out which shows that the neutralizing potential of plasma from people who have recovered wanes off in about 4 months. But remember, antibodies is just one part of the immune system. You have cellular immunity. And whenever we get infected, there is memory that is built into the system, which is recalled when there is another infection. So I believe that much remains to be said on this. And we will see more of this unfold. But I don't believe that somebody who has had the infection once will get the disease again. And there is a difference between infection and disease. As I said earlier, don't mind getting infected as long as there's no disease. It happens all the time. Most vaccines don't prevent infection, they prevent disease.
All right, we're going to leave it there because we've run out of time. Fundamentally, the things that we were told in week 1 still apply. Always wear your mask. Make sure it's a good mask. It's 3-ply, it's washed and it's cleaned. Make sure that you maintain social distancing wherever you go. Avoid leaving the house unless it's absolutely necessary. and sanitize as much as you can, wash your hands as much as you can.
Travel
It's been
safe.
months, I know.
Alone
Yes.
at workplaces.
Sorry?
Eat alone when you eat at your workplace. That's maximum transmission.
Okay, so don't eat in your workplace. Don't eat in public places at all.
If you eat at your workplace, eat alone. Eat in your cabin or eat one at a time with the masks on for the rest of them. I think that's a big take home.
All right, so that's a big take home. Try as far as possible to eat at home. So when my team and I go out to shoot, in fact, we don't use the public washrooms at all. We each carry one bottle of water and we only drink out of that one bottle of water. We don't eat out at all until we go back home, shower, sanitize our clothes completely from head to toe. And then we drink water and we eat. It's what the doctors follow when they're at duty. And I think that's good enough for us as well. But if you don't want to do all of this and it seems like a lot of work, don't go out. Stay at home. Remember, you might think you're fit and young, but you'll wind up giving it to somebody else who might not be able to fight the virus as well as you. Doctors Jameel, Nagral, Tandon, and Patra, thank you so much for giving us time and answering our questions. Hopefully, as we continue to speak, we'll be able to speak under more pleasant circumstances with better news for our audience. But for tonight, the news remains the same as it was in week 1. We're not over this. It's going to continue. We have to be careful, really. The only vaccine available at this time is just being protective of yourself and your loved ones. Sanitize everything. Be super careful. Always look over your shoulder. Thanks for watching. Stay home and stay safe. Good night.
Thank you. Good night.
Thank you.